Bismillah ar-Rahman ar-Rahim. In the name of Allah, Mustafa Abd Rabbi, presenting to you a nice case of severe mitral regurgitation. This case is a 58-year-old female patient. She was complaining of shortness of breath for 1 year, with progression of symptoms and decompensation over the last week, which led to her admission. As we can appreciate, the left atrium looks dilated, the left ventricle is not dilated. However, posterior wall is not contracting well and not thickening well. It looks hypokinetic. Posterior mitral leaflet is a little bit restricted in systole, showing restricted motion in systole, which we call tethering. The anterior mitral leaflet is prolapsing. It's a little bit prolapsing. And the chordae, here is a funny thing seen that will be appreciated in other views. Again, as you can see, there is query rupture chordae here. However, the anterior mitral leaflet is not flail, it is just prolapsing. However, the tip is not yet, is still looking toward the ventricle. With color Doppler appreciation showed severe eccentric posterior directed mitral regurgitation. In flail, you don't get it like this. It does not look that downwardly. It's around 90 degrees. Aortic valve shows no pathology. The mitral valve shows prolapsing A2. This part of the mitral valve is excessively moving, so we are seeing some disease in A3 and A1. There is more showing excessive motion here and here. In this color compare, we can see that the regurg is eccentric and of large volume, and the effective regurgitant orifice area is probably severe. So in this view, this is the apical fourth chamber showing normal contractility, little bit hypokinesis in the lateral wall. The bicommercial view, which is focused on A2, showing excessive motion, which is not focused, it is showing P1, A2, P3, showing excessive motion here. As you can see, the A2 is showing excessive motion. Here we know that this is not a flail chordae, but this is an elongated chordae, which is a finding not that commonly seen in prolapse. The standard apical fourth chamber did not show it very well, so with bit angulation, and should always search for the largest neck and the best view to see the behavior of the mitral regurgitation for better quantification. So with little bit angulation, found out that this is severely eccentric. It is impinging over the wall and reaching almost the pulmonary veins. Also, it might be swirling. However, this is not very obvious here. Again, there was no significant aortic valve disease. When we measured the vena contracta, it was around 0.9. The mitral valve radius, mitral regurgitation radius is 1.1. This is at 37 Nicosia limit, and with getting the mitral regurgitation peak velocity, we were successful to calculate the effective regurgitant orifice area, which was 0.48. We did also transesophageal echo, however didn't add anything to this. So usually we get one etiology per patient. Well, this patient has a dual etiology. What are the etiologies? First etiology is prolapse of A2. This is the main contributing part of the mitral regurgitation, which is probably led to gradually increasing mitral regurgitation that was gradually progressive during the last year. However, what led to decompensation, this sudden compensation, is not flail of the aortic valve, a flail of the A2, however, but ischemic affection of the posterior mitral leaflet. The ischemic affection of the posterior mitral leaflet, which usually affects the whole mitral valve apparatus, including the annular tissues, which has some contractile functions that is lost with ischemia, the papillary muscles, which lead to tethering, and in the extreme form it leads to papillary muscle rupture. Here the ischemic affection led to decompensation of this patient and led to these symptoms. So what was our decision? Decision was to go for coronary angiography as preoperative assessment. We found it to be ischemic with two vessel diseases, and our decision was to go to mitral valve replacement plus CABG. Can mitral valve repair be successful? This is a possibility. However, in the presence of ischemic mitral regurgitation and this dual pathology, the results of repair are not anticipated to be very good. In the end, thank you, and please support us by subscribing and liking our content. If you have any questions, just contact us. We respond anytime.